السلام عليكم ورحمة الله وبركاته. هنتكلم النهاردة عن الإلكترولايتس and acid base balance. الأول هنتكلم عن الإلكترولايتس من الناحية التخديرية، الحاجات اللي هتهم طبيب التخدير. طيب إيه هو الإلكترولايت؟ الإلكترولايت is a substance that will conduct electricity when dissolved in water. هنلاحظ هنا إن الصوديوم كلورايد in solid state لما بيدوب في المية in aqueous بيتحول لصوديوم ion and chloride ion. Both can conduct electricity. In water هنا non-electrolyte ethanol doesn't dissociate to its particles وبالتالي مش هنلاحظ إن اللمبة بتنور. Electrolyte importance as it affects the water movement. Here there's a semi-permeable membrane that allow water movement and doesn't allow electrolyte and particles movement. Particles will attract water by the property of osmosis, so the water content on the right side will be much more than the left side. Also, electrolyte affect the contractility and conductivity of the cardiac muscles. Here in the action potential, we will see that in each limb there is an electrolyte responsible for this. Nervous system also affected by the concentrations of electrolyte, which is the most abundant electrolyte intracellular is the potassium, and extracellular is the sodium. Electrolytes play an important role in sweat formation. There is excretion of sodium and chloride, and this will determine the fluid that is excreted by sweat. Electrolytes play an important role in muscle contraction, especially the calcium and the potassium ion. What is the most abundant extracellular cation? Cation is the positive ion. From this table, we will notice that the sodium has the highest concentration. Sodium is the dominant extracellular cation and is responsible for much of extracellular fluid osmolality. Dysnatremia is typically associated with disturbed extracellular fluid volume. What is the most abundant intracellular cation? From this table, we will notice that the potassium has the highest concentration intracellular. Potassium is the dominant intracellular cation. Cation is a positive ion with a key role in the maintenance of transmembrane potential. This kalemia may be accompanied by impaired function of excitable tissue. Again, we will notice that cell membrane will control the concentration of electrolytes across the cell membrane, and that's why we don't have these semi-permeable membrane in our body that allow free movement of electrolytes throughout our body. What is freely mobile in our body is the water, and the water will constitute around 60% of our total body weight. 66% of these are intercellular and 33 are extracellular. 33% of these extracellular are divided into 25% in the interstitial fluid and 8% in the blood and plasma. Another diagram showing the total body water constitutes around 60% of our weight. Most of these fluid are intercellular and around a third is extracellular. Now I will discuss two clinical scenarios in short about the electrolyte disturbance during anesthesia. In this case, we have a male patient suffering from urine retention. due to prostatic enlargement. Here, the urethra is patent. In this image, the urethra is obstructed by the enlarged prostate. The procedure which will be done is to resect the prostate to open the urethra again. This patient received intrathecal anesthesia, Bengal Nasfi, and this procedure used irrigation fluid uh, to expand the urethra again under pressure and to resect, and at the same time to wash out the blood during the procedure. The irrigation fluid used uh, called glycine. During this procedure, the patient suffered from neurological manifestation. The glycine used is 1.5%. Uh, it's a sterile, non-biogenic aqueous solution suitable for urological irrigation. This solution is slightly hypotonic, that is 230 milliosmol per liter, and the normal osmolality of the blood and body fluids is approximately 290 milliosmol per liter. So this patient suffered from 2RB syndrome. This is a clinical diagnosis based on symptoms and signs caused by excess absorption of irrigation fluid, which is hypotonic, into the circulation. It occurs due to acute changes in the intravascular volume as the surgeon dissects the prostate. There is open vessels that allow entrance of the irrigation fluid. What happens next? The plasma sodium concentration drops and hyponatremia develops. Also, osmolality drops. هنا دكتور التخدير هيلاحظ إن في cardiovascular manifestation such as bradycardia, hypertension or hypotension, elevated central venous pressure, angina, ECG changes due to severe hyponatremia, electrolyte disturbance, sometimes reach cardiovascular collapse. On the other side, central nervous system also has some manifestation like visual disturbance, nausea, confusion, coma. Managing such case will be correction of hyponatremia, which must be corrected slowly. That is around 5 to 10 millimole per liter in the first 24 hours. Because rapid correction will cause central pontine myolysis. Here, in this MRI image, the bonds looks normal, while after rapid correction of hyponatremia, central pontine myolysis is shown in this image. To simplify what happened, here this is a normal brain size, and in normonatremia. In case of 2RB syndrome, acute hyponatremia developed, serum sodium dropped, and water content in the serum increased. Water is freely mobile, shifted from the extracellular compartment to the intracellular compartment, causing enlargement of the brain, increased intracranial tension, decreased the blood supply to the brain, impaired consciousness. If rapid correction of the sodium, it will cause osmotic demyelination. The brain will shrink, water will exit the brain cells and cause the osmotic demyelination. That's why correction must be slow. In this image, we will see the normal cell size in normonatremia, while in hyponatremia cells enlarge, and in hypernatremia cells shrink. Here in this second case, this patient suffered from trauma in the cervical vertebrae at the level of C6. This trauma is considered as upper motor neuron lesion. Motor endoplate respond to this injury as proliferation of extrajunctional receptors of acetylcholine. If the anesthesiologist used succinylcholine, which is a depolarizing muscle relaxant, in general anesthesia to intubate the trachea, hyperkalemia may develop. This hyperkalemia is caused from the depolarizing and fasciculation caused by succinylcholine. Sudden increase in potassium level, in serum potassium level, may cause cardiac arrest. Causes of hyperkalemia, like cellular movement of potassium from intracellular to extracellular, adrenal insufficiency, renal failure that fail to excrete potassium, excessive potassium intake, or drugs like potassium sparing. Signs and symptoms of hyperkalemia include muscle weakness, urine output little or none if in case of renal failure, respiratory failure due to muscle weakness, decreased cardiac contractility as potassium is a cardioplegic electrolyte, early muscle twitches and cramps, rhythm changes, 12 big T waves, and prolonged PR interval. To treat hyperkalemia, there is many goals. First of them, to stabilize myocardial cell membrane if ECG changes happen. We use calcium gluconate. We use hypertonic saline. The second goal is to restore its redistribution. That is to shift potassium intracellular. We use glucose and insulin. We use sodium bicarb as alkaloses shift potassium intracellular. Also, beta agonist shifts potassium intracellular. Also, the third goal, we enhance excretion of potassium through using Lasix or hemodialysis or potassium chelating agents. We finished now the electrolyte imbalance and its effect on body and what is the role of anesthesiologist to control the electrolyte in the body. Now we are going to discuss the acid-base balance. To monitor the acid-base balance in our body, we use the pH. pH is the negative log of hydrogen concentration. Hydrogen is a proton and the pH range from 0 to 14. If we have a pH below 7, it is acidic and it means that the hydrogen concentration is high. If the pH is more than 7, the media is alkaline and the hydrogen concentration will be low. In this image, gastric juice pH is equals 2, the apple juice equals 3, the tomato juice equals 4.2. All of these are in the acidic side, while the human blood is little bit in the alkaline side. Its pH is 7.4. Homeostasis of the pH is tightly controlled. That is, extracellular fluid pH equals 7.4 and the blood pH ranges from 7.35 to 7.45. Death occurs if pH is below 6.8 or pH more than 8. Acidosis that we can treat if it is below 7.35 acidosis for the body, our body, till 6.8. Below this range, the patient will not survive. Also alkalosis up to 8, and above this range, the patient will not survive. As we said that the normal pH range from 7.35 to 45, acidosis below 7.35 and alkalosis more than 7.45. We have the bicarbonate buffer system with a fixed ratio of carbonic acid 1 to 20 particles of bicarb. The importance of pH in our body is that most enzymes function only in a narrow pH. Here in this diagram, we see the rate of enzyme activity that will increase with optimization of the pH. Also, acid-base balance can also affect the electrolytes, sodium and potassium. If we have acidosis extracellular and the cells want to regulate the pH, which is due to high concentration of the hydrogen ion will be shifted intracellular in replacing the potassium. Potassium will increase extracellular, causing hyperkalemia and its affection on the heart. pH also plays important roles with hormones. To control the pH in the body, we have first line of defense against pH changes, which is the chemical buffer system, including the bicarbonate, phosphate buffer system, and protein buffer system. We have also a second line, which is the physiological buffers through respiration and renal mechanism. Bicarbonate buffer system acts within few seconds. Respiratory regulations act within minutes with good response in 2 hours and complete action within 12 to 24 hours. Renal regulations start within few hours and complete by 5 to 7 days. The body always tries to normalize the pH, so carbon dioxide tension, and bicarb rise and fall together in simple disorders. Compensation never overcorrects the pH. Lack of compensation in an appropriate time defines a second disorder. Require normally functional lungs and kidney. In this image, if acidosis occurred, that is pH will be below 7.4, there is an increased concentration of hydrogen ion, which is caused by either accumulation of acids or loss of bases. On the other side, in alkalosis, the pH rises, and it is due to loss or decrease in concentration of hydrogen ions, either loss of acids such as in vomiting or accumulation of base. In respiratory acidosis, CO2 will react with water normally present in the body. Through the carbonic anhydrase enzyme, carbonic acid will be formed, which can be dissociated to hydrogen ion and bicarb. What occurs in respiratory acidosis is that the CO2 level increase beyond 45 mm mercury, causing the carbonic acid to increase. From this image, carbonic acid ratio to bicarb is 1 to 20. In case of respiratory acidosis, we have carbonic acid more than the bicarb. What body compensation will do is to increase the bicarb, and it will take some time because kidneys correction take times to correct. So what is the causes of CO2 hypercarbia, CO2 increased in the blood, which is hypercarbia, depression of the respiratory center in the brain that is controlling breathing rate, either due to drugs or heat trauma, or paralysis of the respiratory or chest muscle, or emphysema. In case of respiratory alkalosis, carbonic acid will decrease. Here, the bicarb is more than carbonic acid. The causes of low carbonic acid is hyperactive breathing, that is CO2 wash. Body compensation will be to decrease the bicarb from 20 to 15 in this example by excreting bicarb through the kidneys to form an alkaline urine. Causes of metabolic acidosis is loss of bicarb through diarrhea or renal dysfunction or accumulation of acids such as lactic acid or lactic acidosis or ketones, or failure of the kidney to excrete hydrogen. Here bicarb will be much low than the carbonic acid. Lungs tend to excrete or to wash out the CO2 to decrease the carbonic acid, and kidneys, if there is no renal impairment, tend to secrete acidic urine and to preserve or to conserve the bicarb. Sometimes we can use lactated containing solution like lactated ringer, because lactate in the liver is converted to bicarb, and which can increase the bicarb in the serum. As we mentioned, that the metabolic balance is that the carbonic acid is 1 to 20 particles of bicarb. In metabolic alkalosis, bicarb will increase because loss of chloride ions or excess ingestion of sodium bicarb. Carbonic acid must be corrected through respiration, that is, hypoventilation will occur or breathing will be suppressed to hold CO2 inside the body and to interact with water to increase the carbonic acid. Causes that lead to excess bicarb in our body is excess vomiting, that is loss of stomach acid, excessive use of alkaline drugs, certain diuretics, endocrine disorders, heavy ingestion of antacids, or severe dehydration. This table simplifies what the disorders in metabolic acidosis: pH decrease because hydrogen concentration increase. Primary disturbance may be due to low bicarb, and the secondary response by the lung is to wash out the CO2 and decrease its tension. This image also simplifies what happens to compensate the pH disturbance. Thank you.